Well, today we are going to be discussing observation. That's where we're going to start the class. As a reminder from last week, though, a brief review. First several weeks of class are going to be largely theory. And I think the theoretical classes are probably the most important of the classes. When it comes to the hands-on part, performing active, passive, resisted range of motion, it's relatively straightforward. And chances are you already have at least some grasp on it. It doesn't take a lot of time to become at least skillful at it, if not proficient. Special tests, even less so, and I'll emphasize them probably today, but special tests account for such an incredibly small portion of your overall assessment that the time spent on them should be relatively minimal. But when it comes to the quality of your assessment, it really is about the history that you take, your observation, your palpation skills. So what we are discussing in this beginning portion is essential. And in addition to that, we're also going to be discussing the theory behind how and why we do our physical assessment. That's active, passive, resisted, and special tests. So again, this theoretical knowledge, while maybe a little bit dry at times, is certainly incredibly important when it comes to understanding the overall theory behind assessment. And last week we went through our introductory concepts about what orthopedic assessment is, and I'll stress and emphasize that it is a systematic approach. That's probably the most important thing to understand, is it's systematic. We do it the same way every single time, no exceptions. In the beginning. Now the reason I specify in the beginning is once you have a very firm grasp on orthopedic assessment, and you've gone through the process several hundred to 1,000 times or so, you'll be able to modify and play around with the systematic approach slightly. You might change the order a little bit based on what makes more sense with that presented case. But in the beginning, again, it's systematic every single time. I introduced to you the way that we go about conceptualizing assessment, and it's the HOMS-P method. That's HOMSP. And this is our systematic approach. Every time you see a client, you need to be performing all 5 of these aspects. H, history. O, observation. M, movement. S, special tests. And P, palpation. Now the reason I wrote it in this order is it should go in this order, and the P is separate because palpation is performed at any given time. Some people say you perform palpation specifically after these special tests, but my opinion is when I'm going through history, sometimes I'll ask if I can palpate. They'll say, my arm hurts here, and I'll just say, can I palpate it? And I'll palpate, and then I'll continue to ask questions. And then during observation, I might be standing there, or they'll stand there, and I'll palpate their upper traps or something. So palpation is done throughout the entirety of the assessment. However, we begin our assessment with history, which we discussed at length yesterday. I truly believe history accounts for 85 to 90% of your overall assessment.
Hello.
The ability to ask really high quality questions, and much more importantly, interpret and understand the results, that's really assessment. Your ability to ask questions. This is part of the reason why when I'm doing clinical supervision is if you come to me and you've given me the appropriate answers to the appropriate questions, I don't need to go in the room. I don't need to see what's happening. I can gain a lot of information simply by understanding the story behind what is happening. So last week we really did spend a lot of time discussing the questions to ask, to ascertain the story, the subjective results, or subjective information. So today now we're going to start with observation. So within go. Within observation, no, it's stopped. It begins as soon as we see our client. Sorry about this. It'll pop up in a moment. observation begins as soon as we see our client. The moment they walk in the door, the moment we first see them, we're starting our observation. And we're paying attention to many different aspects of the observation, but the first thing I like to notice is how they're sitting. We have the big O, right? And so we've got big O and little o. Big O is very specific postural observations. Big O is going to be, we ask somebody to stand, so we observe their posture. We ask them to move in a specific way. So I consider big O the very deliberate, the specific forms of observation. And there's a time and a place for that. We have the little o also, though. And the little o is that constant observation that we're performing from one end to the other end of the time we spend with our client. So it's the patient's way of moving as well as the general posture, manner, attitude, willingness to cooperate. So when they are sitting in the chair out front, are they sitting with this serious hunch posture? As you approach them, do you watch them, good morning, do you watch them kind of shift in their chair uncomfortably? Are the legs crossed one way or another? These are all minor little o observations. We talked a little bit about it last week, about how I approach my client. When my client is sitting down, I walk up to them, I stand 5 to 10 feet away, I say, hi, good morning, Archie? Excellent. If you just stand up, we'll be in room number 2. And I don't get too close because I want to watch them stand. I want to watch them take a few steps towards me, and it's quick. I pay very quick attention. Their general demeanor. They gotta stand up like this, then they pop up out of the chair, are they holding one arm like this? And as they walk towards me and walk away, I continue the little o observation, just watching them naturally move. Throughout the entirety of the inquiry, I'm paying attention to their general mannerisms. Are they talking low and slow? When they move, do they make a wince? Are they considering the pain a little bit more? How easily can they answer the questions? All of these indicate severity of pain. Looking for any signs, pain behaviors. These are going to be postures like guarding postures, for example, holding one arm. Visible defects, functional deficits, and abnormal alignments. And again, it's happening throughout the entirety. So we see observation is very deliberate and specific, but also consistent. And the more time we spend in clinic, and I'll do my best to increasingly point out my observations in your own behaviors. Not to pick at what you're doing, but it's helpful, right? If we're sitting there and you're working on each other and you're both in the room, I'm going to be saying, did you see that little thing that your partner did? Did you see that posture shift? I'll point it out so you can start to gain these skills a little bit more rapidly. Now, much of our deliberate big O observation is postural assessment. It's getting our client to stand and we check out their posture. When it comes to postural assessment, we need to understand that it's difficult in the beginning. Like it's a very difficult thing in the beginning, but there tends to be a moment when it clicks. When all of a sudden you can see posture much more readily. You can see how the entire kinetic chain starts to change. And I might get into this later in the slides. I can't remember if I put the point in there. There's a continuing education course that you could take with a guy named Thomas Myers, and it's called body reading. And when I took that course, I found it to be one of the most useful skills that I gained outside of how to ask questions. Body reading is essentially postural analysis, but taken up one notch. Instead of just asking somebody to stand there and say, oh, they have forward head posture, immediately rotated shoulders, and anterior pelvic tilt, and genu valgus. Right? Those are very simple observations. Eventually, with body reading, you'll be able to look at somebody's posture, and you can identify there's a fallen arch on the right foot that's causing external rotation of the right knee. And that external rotation of the right knee drops the right leg slightly, which then causes the left hip to tilt slightly forward. You see, you can move up the entire kinetic chain.
What's the name of it again?
Thomas Myers. So I tell you this to say, when we begin our postural assessment, it's incredibly basic. And as we go through each one of the different dysfunctions, as we go through each region of the body, I start each region by discussing the common postural dysfunctions, We keep it very simple. We don't dig too deep into it. And once you have a firm grasp on the simple aspects of postural assessment, then I would encourage you to continue on your education and take a course such as body reading.
Were you able to claim that to continuing it?
Mm-hmm.
Awesome.
Yep. All right. Essential to understand that a large portion of dysfunctions come from poor posture. I'm sure everybody in here was with me at some point in time during massage, and I taught posture every single day. Every day I talk about how postural dysfunctions lead to the common issues that we see clinically. As a massage therapist, realistically, the number of injuries that you treat will make up for, at best, 50% of your practice. But more realistically, you're probably looking closer to 20 to 25% of your practice is going to be spent identifying and treating injuries. The other 75% is going to be spent working on chronically hypertonic muscles due to poor posture. And that's just the way that massage therapy has become, or is commonly used in Canada at the very least. So it's very essential to understand posture leads to joint instability. And what do I say about joint instability? When a joint becomes unstable, thank you very much, all of the muscles around it become hypertonic to stabilize a joint. When somebody comes in to see a massage therapist, assuming it's not strictly for relaxation, but even so, what do they say 9 times out of 10? I have tight muscles. My neck is tight, my shoulder's tight, my low back is tight, my hips are tight. They say I have tight muscles. Did you injure anything? No. Joints unstable, muscles become tight. Why are the joints unstable? It's poor posture. Postural assessment does indeed require significant time and practice to become proficient at. I would suggest do it as often as you possibly can. Just observe, watch people. When you're standing in line at the grocery store, just look at somebody's posture. Try and pay attention. What's going on in their pelvis, their head, their shoulders. Observe as often as you can. Now, it is a topic of its own meaning. We could take postural assessment and turn that into a 6-week class. We could easily spend 6 3-hour classes discussing postural assessment in the form of, say, body reading or even advanced postural assessment. So I really do need to make sure you understand that. It's a vast topic. Fortunately, there's a lot of apps for postural assessment, and that's what I use a lot of the time. I developed the skill of body reading and being able to perform postural assessment, but the apps make life way easier. You don't need any special equipment. If you do proper postural assessment, you need a big grid board that's on the wall that would take up this entire wall. You might need a plumb line that hangs from the roof with a string that hangs from the roof. To perform proper postural assessment, you need space and equipment. Apps, on the other hand, do it all for you. You just take a picture, you put dots on the shoulders, the hips, the nose, the belly button, and then it will tell you, oh, this person has an elevated shoulder by 10 degrees or something. So there are apps, and I would encourage you to look at them. Posturalanalysis.com, that's probably my favorite of the apps. I believe it is now a subscription-based app, a certain number of dollars per month. And it might even be a credit-based app, meaning you pay like 10 cents per patient that you take a picture of. I can't remember their charging scheme right now, but it's relatively inexpensive, all things considered. And if you do a lot of postural assessment, it's worth getting a good app. They're increasing the complexity of the app all the time too. They're now, I think it was like a year ago, they released a sitting postural assessment, so you can get somebody to just sit, take a picture of them, and assess their posture. And they're working on GAIT analysis as well. Posture Zone, cheaper, not as good. I think they have a free version as well, and you can use. And they're available on all mobile devices. Easiest to use a iPad though, bigger, easier. As I mentioned, usually we require a reference of some sort if you're not using an app. You need a grid line on the wall. We need a plumb line. We need something to rely on other than just our eyes. Ideally, patients are wearing shorts, so if you're working on a male and they're comfortable with it, just shorts is ideal. And it's even more ideal if the shorts are quite tight, because we do need to see all the bony landmarks and be able to palpate quite easily. And with female patients, ideally, it's good for them to wear shorts, a bra, halter top, something like that. But you want to see as much of their body as possible. We look at skin folds and contours as well, so quite difficult to perform a high quality postural assessment when somebody is fully clothed. If you plan on performing postural assessment, it's part of the process for you. It's worth informing your clients beforehand that they need to come prepared for that, to bring in shorts or bring in a sports bra or something. Again, that's only if you choose to perform this regularly. You need to explain to them what postural assessment is, because it's a very strange thing when somebody performs postural assessment, right? Like, actually, would you mind if I perform a quick postural assessment? Just stand right there. Maybe you come up. So when I perform a postural assessment, and you can look towards me, and I want you to just notice what I'm doing. No, you don't mimic
Okay.
me, but just see, I'm really staring, right? Staring at your shoulder. You can have a seat again. So as a client, to have somebody just stare at every little bit of you, it's uncomfortable. And if you're wearing almost no clothing, it's even more uncomfortable. Just imagine you're standing up here now, basically in underwear, and you have somebody looking at every little contour and every aspect of your body. It's uncomfortable to have somebody perform a detailed postural assessment. And if an individual has confidence issues or they're uncomfortable with their body, you need to explain exactly what we're doing. So make sure you communicate clearly during postural assessment what you're looking for. Another thing that I would encourage you to not do is tell them what you find. When it comes to postural assessment, you might imagine you've got great posture, but at some point in time, I will do a postural assessment for all of you, and I'll tell you exactly what I find. Chances are, by the time I get to your knees, you're going to be fed up with me telling you how horrific you are. Because that's it, it's your foot is externally, blah, 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 blah. There's a lot wrong with posture. And if you start telling a person all of the things that's wrong with the way that they're standing, it's kind of hard to hear. Just keep it to yourself. If they're really interested in what's happening, you could tell them a few of the major findings, but don't inform them about every little detail that you find. Largely in the beginning, what we're looking for is asymmetries, and determine if the asymmetries are significant and applicable to the problem being assessed. Large asymmetries, right? So for example, if I were to stand here, right, so with large asymmetries, for example, if I were to stand with my shoulders, they're relatively similar, but a large asymmetry would be an elevated shoulder on the left and a depressed shoulder on the right. That's a significant asymmetry. But there might be a minor asymmetry, and we need to determine, is that minor asymmetry, which is difficult to see, does that contribute to the problem? We do pay attention to the asymmetries. Another example of an asymmetry is if I stand here quite normal, just pay attention to my arms in relation to my torso, right? So with my arms in relation to my torso, what's the space like in between my arms and my torso? Is it the same on both sides? Slightly laterally flexed, is it the same on both sides? Look at the difference. Here, here. I was degrees of lateral flexion on my torso, and yet my arms are in a totally different position. So look for those asymmetries. Pay as close attention to the asymmetries as possible. So far, so good. Any questions about postural assessment? What are we looking for? When we perform postural assessment, it again is systematic. We always start at the feet, and the person needs to take their shoes and socks off. We need to be able to see the bare feet. We start at the bottom and we work up. Quick side note, when it comes to postural assessment, there are three schools of thought, which I've mentioned before. There's the ascending school of thought, the descending school of thought, and the central school of thought. The ascending school of thought largely focuses on the fact that dysfunctions of the foot and ankle can manifest up the kinetic chain. If you have fallen arches, that can result in, say, slumped or an elevated shoulder. The descending school of thought believes if you say have a forward head posture, it's going to eventually move down the kinetic chain and alter your gait. The pelvic school of thought believes if you say have an anterior pelvic tilt, that's going to alter your gait and your biomechanics of your foot, as well as say cause a forward head posture. So there are different ways of going through the process of postural assessment. I think it's important to understand all three of them. And as we go through each region of the body, I'll discuss ascending, central, and descending postural dysfunctions. However, when it comes to how we perform postural assessment, systematic. Step at the feet, move up. Same thing every single time. You'll get used to, you'll have a more keen eye for potential dysfunctions. Again, we're looking for asymmetries to determine whether the asymmetries are significant. These patterns reveal information about muscular tension, previous injury, tissue dysfunction, potentially congenital disorders. Things like scoliosis, could be congenital, could be functional, structural, or functional. We could see elevated shoulders, medially rotated shoulders, forward head postures, all the common things we've discussed, which tell you largely what you're going to work on. So if you see somebody with a little O, and they're sitting in the chair. Now, when somebody sits in a chair, most people, in fact, I would say within this class, your guys' posture, sitting posture is average. Meaning, if you sit forward, your shoulders slightly medially rotate, and if you're sitting back in the chair, it's a very mild medial rotation of forward head posture. That's typical, that's normal. On the other hand, if you see somebody sitting in a chair and they're really rolled forward like this, they've got that horrible text neck, and they stand up, and it doesn't really correct itself. So as I stand into this position, I look the same as if I were to be sitting. Little O, we're not doing a postural assessment, we're not using a grade or an app, but you can tell right away this person is going to have very sore anterior neck muscles, pain between the shoulder blades, low range of motion in the shoulders. So you can tell the muscular tension just by observing with that little O.
So the big O is like doing an actual full postural assessment.
That's right.
And the other one's just what you notice.
Just what you notice. Eventually that little O doesn't really turn off. You just constantly notice these things as you train yourself to pay more attention. Mild asymmetries are very normal. As we go through postural assessment, and I perform postural assessment so you guys can see how it's done, if I mention there's a decreased in fixed angle on the right leg by 2 degrees, that's not a big deal at all, because everybody has these tiny little asymmetries. For the most part, we're all dominant on one side. You're right-handed or maybe you're left-handed. Sure, there's ambidextrous individuals, but most people are dominant one side than another. That means you're going to use one side more than another, which means the muscles will be more developed, and you see how these asymmetries are normal. So when you're performing any or either the big OR or the little O with the postural assessment, keep that in mind. Minor asymmetries, don't worry. Obvious deformities, leg length discrepancies, scoliosis, these ones will be incredibly obvious. Figuring out the roots behind them can be a little bit more difficult. These are going to be structural. Are the limb positions equal and symmetrical? The example I gave is my arms in relation to my body. But we could have an elevated shoulder. We might even have one leg that's way out to the side, right? They stand way out to the side on one hip. So look the limb positions for symmetry as well. So far so good. Any questions? All right. So talk about normal posture. And I do use this word normal specifically. Oftentimes in medicine, we try not to use the word normal. The word that we prefer is typical. But I've chosen the word normal here to prove a point, and because normal posture doesn't really exist. There are typical patterns, however, things we would expect. When we perform postural assessment, we perform postural assessment from an anterior position, from a lateral position, and from a posterior position. You do not have to do both lateral positions. You certainly can if you want to. So for the most part, it's only one lateral position. From an anterior view, the nose xyphosternum and umbilicus should be in a straight line. Now it's very difficult to identify this unless you have, say, a string hanging from the roof with a weight, that's called a plumb, or you're using an app. But they should be perfectly aligned. So that's an anterior view, and that's going within the torso up. Lateral view, the tip of the ear, the acromion, and the iliac crest should be in a straight line. Again, we're doing just superior part of the body for this example. Posterior view, the popliteal crease, the PSIS, and the scapula should be at the same horizontal line. So ideally, healthy posture should be well aligned, is the point that I'm trying to make here. And that's it for typical. That's what should exist. Outside of these rules, we really need to take into consideration the person's body shape, their height, their occupation, their gender. There's many different characteristics that are going to change what's considered to be normal or typical posture. But again, anterior, we are really looking for central alignment. It's known as xyphosternum umbilicus. Laterally, we're looking for alignment ear, acromion, pelvis, hip. Certainly we could get into the knees, but things change if somebody has hypermobility. And then posterior are the popliteal creases level, PSIS level, and the shoulder blades level. The most common postural patterns that we see are going to be pelvic cross syndrome, or what's called lower cross syndrome. That's anterior pelvic tilt, right? Pelvis tilts anteriorly. We have upper cross syndrome, forward head posture. Medially rotated shoulders. So with medially rotated shoulders, that's going to be the shoulders are forward of the ear. It can be difficult to note medially rotated shoulders, right? So I stand and you see my thumbs are pointing straight forward and my shoulders look like they're on straight or they're in proper position. But if you see the backs of my hands, that indicates medially rotated shoulders. And then calcaneal valgus. I'll show you some pictures of this once we get into dysfunctions of the ankle and foot, but that's essentially a fallen arch or valgus stress within the ankle. These, in my opinion, are the most common postural dysfunctions. There are certainly far more than this, of which we will discuss, but these patterns are so common that you should be able to identify them very, very readily. Additionally, within the spine, we have kyphosis, lordosis, sway back, flat back, and scoliosis. We'll discuss each of these at length when we get into spinal dysfunctions. But quite simply, we look at this first image, that's A, and that's going to be ideal alignment. We see the plumb line. I don't know if you can see it, so I'm sorry about that. I can't make it bigger on this slide, but the plumb line is going to the ankle, lateral, one line, from the lateral malleolus to the center of the knee, to the greater trochanter, to the acromion, to the ear. You can see perfectly stacked posture. That's healthy. And then we get into the X keeps coming. Get into kyphosis and lordosis. Exaggerated lumbar lordosis. That's anterior pelvic tilt. You see my low back is really curved. That's lordosis. Kyphosis is like this. Forward head posture is like that. So kyphosis, lordosis. Strangely normal, right?
You look so funny when you do different postures.
I really try to exaggerate them.
Also, but your posture is so good, you just look like a different person.
We have sway back. Sway back is when you see the arms posterior. So sway back stands like this. And you can kind of see that it's like there's lordosis, there's kyphosis. So that's lordosis and kyphosis. Sway back is very similar, but standing back like this. You don't see it very often, but you certainly do. It looks strange when somebody's walking like that, but you will certainly see a sway back posture. Flat back posture, it's difficult to produce. And when it comes to flat back posture, I'm not entirely convinced flat back posture is as dysfunctional as some believe. We'll discuss this a lot in spinal dysfunctions, but when it comes to the conceptualization of the shape of the spine, for many years we've been taught that a healthy spine has an S shape. It's not really an S shape, but there's thoracic curvature, lumbar curvature, sacral curvature, and the spine makes this curve, right? What we're beginning to understand a little bit more, particularly through anthropological evidence, is what seems to be a little bit more natural, is a J-shaped spine. It's a very straight thoracic spine, a mild lumbar curvature, and a relatively straight sacrum as well. So when we get into dysfunctional postural assessment, there's schools of thought where one person would say that spine is dysfunctional, and another person would say that spine is healthy. So keep that in mind too.
Can you have, do lordosis and kyphosis always happen a bit with each other?
Yes. To a certain extent, the severity will change, however. And if you try and modify your own posture, just try and give yourself an anterior pelvic tilt without kyphosis, you can do it. So I can stand here, my belly's out, but my thoracic spine is relatively straight. But we don't see that often. What we mostly see is when somebody has lordosis, the kyphotic curve increases. On the other hand, try and do it the other way. Try and give yourself kyphosis without giving yourself lordosis. That's not as easy. So we have the descending is commonly seen combined, but the ascending can be in isolation. And the same goes with forward head posture. I can have lordosis, no kyphosis, and no forward head posture. On the other hand, if I give myself forward head posture, I develop kyphosis and lordosis. It's very hard not to. And that's that descending school.
Is that a compensation? Like, that's why they happen together, is because you're compensating for like the root pattern?
I think you could look at it as a compensatory pattern, but I view it more as a simple biomechanics. Just the way that the spine is structured, and as soon as your head goes forward, compensation or balancing through the biomechanics, you have to bring your weight backwards.
Yeah.
So it's going to be the kyphosis and then forward with the lordosis. So compensation, certainly, or balance.
So then when we're looking to correct that in somebody or to work on it, do we have to figure out like that root problem if they're having several of these things?
Yeah. And then which one to fix first? Fortunately, there's one exercise that you could use to fix them all. I'll never guess what it is. It's a wall angel. Wall angels can be used to help you identify where the primary dysfunction is. Right? When somebody does wall angel, what they should be able to do with a healthy, proper wall angel is they should be able to go up to the wall, heels, bum, shoulders, head, right? That should be an easy starting point. But they might not be able to. You might get heels, bum, shoulders. Head doesn't go back. You got to fix that forward head posture. Or you might get heels, bum, shoulders can't go back and the head does. That's an anterior pelvic tilt. Or you might get heels, bum, shoulder, head. That's fine. But the chances of them being able to flatten that low back, impossible. It's pelvis. So you can start to figure out where you need to focus on based on where's their sticking point. Can they get that back flat? That's usually most people's sticking point. If not, focus here. Can they bring that head back? If not, focus here. We're not talking about shoulders yet because that's going to be the next part. It's a different story. It's simple, deceptively simple, but it's good.
It's so hard.
Yeah, very hard. So it's a very brief review of postural assessment. Remember, the idea here is to introduce you to all of the concepts. As I mentioned, as we go through each region, we'll discuss at length postural dysfunctions. We'll probably spend more time on postural dysfunctions than injuries, even though once you look at your slides, postural dysfunctions are like 10 slides, whereas injuries and other dysfunctions are like 50 slides per region. Don't let the amount of time spent dictate to you the value of a specific topic.
Speaking of slides, could you send them to us?
Sure.
Okay. I tried to find them, but
No problem. All right. Next thing within observation. Contours, colors, scars, and crepitus. Are the bony contours of the body normal and symmetrical, or are there deviations? So, assuming we can see bony contours, which is certainly not always the case, we want to make sure that there is symmetry. For example, and maybe next week I'll bring in a tank top because I have a lot of asymmetries in my shoulders from previous injuries. The AC joint, is it symmetrical on both sides? So myself, the right AC joint has a very clear step deformation, and the left AC joint is typical. So we look at bony contours. Are they symmetrical? How about soft tissue contours? We have muscle, skin, fat, normal, symmetrical. Is there muscle atrophy? In somebody who's just had a cast or surgery, we'd expect muscular atrophy. But in a healthy individual, there should be no difference from one side to another, with the exception of occupation. I've had a patient who was a blacksmith, and he spent all day with a heavy hammer in one-handed arm. His right arm was like the size of my leg. His left arm was relatively typical of what you'd expect. So you may see significant asymmetries based on occupation. So of course we'll ask about occupation. Limb positions equal and symmetrical. We've discussed that already. Compare limb size, shape, position, atrophy, color, and temperature. The color is largely looking at vascularity. You have one side that's, say, really red or potentially even pale in comparison to the other. And then temperature. Although temperature is more palpation, we can start to include it within observation when we combine it with color. Color, does the appearance of the skin differ in the area of pain compared to the other areas of the body? That's looking for signs of inflammation. There'd be redness within a specific area. They've got arm pain and there's a red area. Any scars that indicate recent injury and surgery? It's strangely common that people will come in and say, yeah, my shoulder hurts, and you go through the questions like, what happened? Did you fall on it? And you're like, no, I didn't fall on it. That's a close-ended question. Right? Did you fall on it? No, I didn't fall on it. Okay, well, could you point to the location of pain? You point to it. And then they take their shirt off and you see a big scar. What's that scar? Oh, I had shoulder surgery 6 months ago. So if we ask that close-ended question, we of course would have removed the ability for them to say, I had surgery, but within that scar we can observe it if you ask. Some people simply won't break down. Got knee pain, you ask them all the questions, you see a big scar, they say, oh, I had knee surgery 10 years ago, but they're not thinking their current knee pain could be due to the surgery 10 years ago. So do ask about scars if you see them. Surgical scars, more than anything. And surgical scars are quite easy to identify. They're linear, they follow straight lines, and they typically have suture scars beside. Any crepitus, snapping, or abnormal sound in the joints. So observation has to do with what we observe through auditory means as well. Crepitus is that sound, clicks and pops. And there's normal sounds that you hear in joints, right? So, you've got to move your body around. You'll get all these little clickety cracks. What I found that happened, and by all means, come and ask, but I might as well spoil the fun. I cannot tell you how many times I've had students come up after class and be like, hey, I got this sound. What's that sound in my joint? 9 times out of 10, it's just fascial adhesions. When it comes to crepitus, we use one of my favorite rules, which is no pain, no problem. If there's sound in a joint, it's not causing pain, don't worry about it. It might be the early stages of an issue, might be. But if there's sound in a joint, I'll often say, you need to mobilize. If you use your joints more, go through proper range of motion exercises, stretch, strengthen. 9 times out of 10, that gets rid of the crepitus. But is there abnormal sound and snapping crepitus that's associated with pain within the joints and during movement? Heat, swelling, and redness. Can you observe any of that? Right? That's our main colors, contours, scars, and crevice. Overt pain behavior and general demeanor. Any questions about the scars, crevice? Pretty straightforward. Next is overt pain behaviors and general demeanor. So let's begin with overt pain behaviors. This is the overt pain behaviors are very obvious. And the first is going to be guarding. That's abnormal, stiff, interrupted or rigid movements while moving a joint from one position to another. So with guarding positions, there's a few very obvious guarding positions. One would be, say somebody has a separated shoulder, not a dislocated shoulder, a separated shoulder. That's an AC joint injury. What they tend to do is they'll hold their arm close to their body like this. That's a guarding position. So they guard that. Maybe they have a subluxed or dislocated shoulder. They'll hold their arm close to their body like this. Or maybe they have a groin strain. With a groin strain, they'll hold their hand close to their groin. It's not doing anything, but that's a guarding posture. Maybe they have a sprained wrist. You'll see them walk around when they have a sprained wrist with this right arm. They kind of hold it in front of them. This arm moves just fine, but their sprained wrist, their shoulder doesn't move, their elbow doesn't move. It's like they guard it in this position. They might hold it close to their body. But you see with guarding positions, there's not smooth flow of movements. There's apprehension in movements. That makes sense? It's a guarding posture. Next, we have a bracing. That's a stationary position in which a fully extended limb supports and maintains abnormal weight distribution. So, bracing posture we usually see within the legs more so than within the upper body. And a bracing posture within my hips, for example, might be instead of standing symmetrically, both limbs are my weight is distributed evenly from both limbs. I'm going to favor one side. Maybe this right leg is just barely touching the ground. So it's a fully extended right limb that's going to brace. If somebody's near a table, for example, what you can see if they're near a table is they'll extend their arms and they'll lean on the table to take weight off their low back. It's a bracing posture. Next we see rubbing. Rubbing is relatively straightforward. It's rubbing. People unconsciously rub painful areas all the time. Try just imagine when you were a kid and you fell down and bumped your knee. You'd rub it. We all do it to this day. You bump your head, you rub it. So rubbing. And you see people rub all sorts of places. Unconsciously, usually. You'll be in the middle of a conversation, and if it starts to ache, rub. You see people rub their back. So rubbing. Next we have grimacing. Grimacing, of course, is a facial expression. So as they go to stand up, they grimace in pain. They get that overt pain expression on their face. As you go through range of motion, they lift their arm and they go. So it's that facial expression. Make sense? Sighing. Obvious exaggerated exhalation of air, usually accompanied by the shoulders first rising and falling. Patients may expand their cheeks first. So there's several types of sigh. There's the sigh we love to hear when somebody's on the table. And it's like this sigh of calm relief. But then there's the where you kind of expel air through expanded cheeks or bloated cheeks. You push that air out, and it's when you're in pain. It's painful. So it's similar to grimacing. Oh, what just happened there? Wrong button is what happened there. Please start from the correct slide. Good. Okay. How are we doing so far, so good? Great. General demeanor would be next then. What attitudes does the patient appear to have toward the conditioner, towards the examiner. And it's non-judgmental, right? We're not judging them as having a good attitude or a bad attitude. It's simply, what is their attitude? Not sure if you've ever been in chronic pain, but it's really difficult to keep a positive attitude. Now, what's unfortunate about that is attitude plays a fairly significant role in long-term healing. So somebody comes in, they've had low back pain for 10 years, and they're like, I don't know, I want a little bit of relief. I don't expect it to get better. And they're, see my demeanor, my attitude is, I'm not happy about it. Whatever, who cares? So it doesn't determine your treatment necessarily. It just helps you understand how they're going to be participating in their own well-being. Are they apprehensive, restful, resentful, depressed? The emotional diagnosis is not within our scope, of course, but again, it helps us understand their willingness to participate in the treatment plan. And you do need to know that. If somebody's coming to you expecting you to fix them, that's of course transference, and at best expecting you to help them heal, if they're not willing to participate in their own healing, then it's very difficult. What's their facial expression? Is their facial expression one that's kind of drawn and painful? Has anybody in here worked with or been around somebody who's been in chronic pain for many years? You can see it in the eyes, right? The eyes get sunken. Their cheeks oftentimes get drawn. They get pale. They get bags under their eyes. They look ill. They look like they've had a disease for many years. And in fact, they have. And it's a disease of chronic pain, if we could call it that. So look at their expression. And that tells you how serious this really is for them. Does the patient appear to be apprehensive, discomfort, lacking sleep? Helps to know if their pain is affecting their sleep. Is the patient willing to move? Are they willing to for example, you've got them face down on the table. You say, I need you to roll face up, and they kind of give that, not the happy sigh, that like, okay, let's do this kind of sigh. Are the patterns of movement normal when they are moving around? Now, general demeanor, as we've seen, it doesn't really determine the quality of treatment or the prognosis of the treatment or outcome. But really, it's helpful for you more than anything to understand your patient. It helps you build rapport a little bit more. It helps you understand their subjective experience a little bit more. Cool. We'll move on to GAIT unless there's any questions. Well, that first note is the most important thing to understand about GAIT. It's complex, very complex. We understand now that posture is simple in some regards, right? We have our basic postural dysfunctions, and it can become more and more complicated. As we get into something like body reading, you can see how minor dysfunctions compound over a lifetime, and that's the simple standing posture. GAIT is considered to be moving posture, and there are many different aspects to GAIT. So the two main phases of GAIT are swing phase and stance phase. We have about 60% of the time spent in stance phase, and 40% is then going to be spent in swing phase. So when it comes to standing posture, both feet firm on the ground. Both feet are going to be firm on the ground. They stand, they look straight at you. When it comes to moving posture, it's totally different. Moving posture is, I'm looking at the stance phase on the right foot, simultaneously paying attention to the swing phase of the left foot. Now I'm paying attention to the stance phase on the left foot, paying attention to the swing phase on the right foot, paying attention to the stance. And I went slow. And maybe get somebody to walk at a normal pace. You can see how trying to observe stance phase and swing phase and all of the different things that happen, without really getting too deep, but during each one of those phases, during stance phase, I break it down into heel strike, roll, toe off, weight distribution. So within each one of these phases, we break it down into one. So this isn't to scare you off of GAIT, but it is to inform you that GAIT is hard to become incredibly proficient at. And if you are interested in GAIT, which is super fascinating, I would encourage you to get continuing education that teaches you how to work with machines. Somebody standing on a treadmill with a set of high-speed cameras, That lets you just film them for 5 seconds, watch them take a couple steps, and then you can go back, sit on the computer, and analyze it. Gait analysis, biomechanic analysis, that's a huge, huge area of study. So with that said, there are some very common and simple gait patterns that we can observe. We have an antalgic gait, or a painful gait. A painful gait is a typical limp, right? So there's nothing too special about it. When we talk about a simple, painful limp, all seen somebody limp. It's less time spent in the stance phase. That's it. So I step on my right foot, just less time spent. Easy enough. We don't need to care about exactly what's causing it. This could be part of the small one. As somebody walks towards the room, you notice a limp or an antalgic gait. Easy enough. We have a gluteus maximus gait. Gluteus maximus, the glute max is responsible for extension of the hip, right? So as I take a step at my stance phase, and in order for me to go through the swing phase, I have to extend that hip. So if you watch me walk nice and slow, I'll plant on my left foot, my glute max contracts, extends my hip, pulls me forward. Now imagine my glute max doesn't have the ability to do so. I extend my back instead of my hip. See that? So my hip isn't extending, my back is extending to perform the same movement. It's a glute max. Now I'm exaggerating it so you can see. So if I slow it down a little bit, and then I perform it as you may see typically. So I'm still extending my back instead of my hip.
Can you do it again with your, exaggerating what you're doing?
With my left, yep. So I stance phase, my back extends.
Not with the back part, like the normal one.
Oh, how you typically see it. Yeah.
Or with if it's not dysfunctional.
Oh, like a normal gait.
Yeah.
So normal gait like this. As I step, my hip is going to extend. Plant, hip extends to drive me forward. Plant, hip extends to drive me forward.
Okay. Yeah.
So when people are leaving the gym.
Yeah.
Yeah.
Yeah, that's been an epic leg day. Don't bend the knees, don't extend the hips, just waddle. Totally.
So why does that happen?
Glute max dysfunction. It could be an injury to glute max or a neurological issue. Pardon me?
It can be from being too tight or
Too weak, typically, or a neurological dysfunction. There's been a herniation. I mean, I should take a side note, and I said we take a step, and then we extend our hip with our glute, and in fact, I'll strongly encourage you to do this, and I may actually make everybody do it just before break. Is stand up, grab your bum, and walk. What you should not feel is contraction of your glutes. The glutes typically only contract when we're going uphill or when we're going upstairs, because more realistically, a healthy gait is we lean forward first and we let gravity take over. And it's a set of reflexes. This is a really fascinating thing. It's a sad story, but interesting story. There has been studies where they have taken paraplegics and put paraplegics, so that's individuals who have no function of the waist down, placed them over top of a treadmill, slow treadmill that started the leg going into a walking position, so place the foot on, and as soon as their feet started walking, reflexes kicked in and their legs moved in a walking type pattern, being suspended. And you see the same thing with pretty much anything, but you imagine you take a puppy and you hold it over water. You ever seen those cute little videos? Hold a puppy over, like a bathtub. We're not drowning puppies, right? It's over a bathtub and the little puppy starts to swim. Because swimming and walking are very similar reflexes. All we do is we start the reflex and it goes. So it's more of a flexion of the hip and extension of the hip. Regardless, if somebody's glute max is offline, they still extend. Glute medius walk, this is also called the Trendelenburg gait. Oh, the Trendelenburg gait. So there's a few ways that you can see the trend in the group. The first and most common that you see in chronic gluteus medius weakness is going to be what's called a lurch, more appropriately a translumbar gait. It's going to be my right leg. I plant, laterally flex my torso. So my glute med does not stabilize. Left leg. So the glute med, its job is, or its action is abduction of the hip. How many times in a day do you do this? Like actually, do you lift your leg out to the side? Probably like 0, maybe? Get out of the car? Get out of bed? That's about it. But the glute med is firing every step we take, because as I take a step, what the glute med does, as soon as I plant, the glute med does indeed abduct the hip. It pulls my leg out, and that stabilizes my pelvis. Standing here, this is isometric abduction of my hip. It's a strange way to conceptualize it, but that's the motion of the glute med. So if I cannot abduct my hip, I have to throw my body over my hip instead, because it's not stabilizing myself during the gait. On that one. So that's a rapid speed, Trendelenburg gait, or a lurching gait. That's one way that we can see it. That's in chronic cases. In acute cases, call it the model walk. Glute med weak, hips go to the side. Model walk. Because I mean, I'm doing it on both sides. It'd actually be just on one side. It's both sides for sure. But that glute med weakness prevents abduction of the hip, and the hip pops out to the side. We see it in Trendelenburg posture as well. Somebody stands, and you try and get them to stand, and the hip keeps popping. So that's glute med weakness.
How do you, when you're looking at someone's gait, how do you tell between like a muscle dysfunction and then like something's wrong generally, or like bones, or how do you tell when it's a muscle thing?
In the beginning, you don't. You just observe the gait. And then as you go through your inquiry and the rest of them, you'll start to understand, okay, this person is born with, say, scoliosis or small innominate or something like that.
Typically muscle.
Typically. Quadricep avoidance gait. So we don't want to use our quadriceps. So that's going to be a stiff knee, right? The quads extend the knee and flex the hip, but largely during gait, they're responsible for isometric flexion and extension of the knee. So instead, right, when I take a step, my knee flexes, my quadriceps extend my knee, and I'm walking stupid, right? Of course. We don't actually walk like this, but I'm exaggerating the movement so you can see that when I take a step, my knee bends, and then when I go through my stance phase, my knee extends to allow my other knee to go through extension. So walking requires contracted, concentric contraction, weight bearing, and concentric contraction during the swing phase. So there's a lot of extension of the knee. Now, quadricep avoidance, they don't want to take the weight into their knee, so the knee stays straight. You see how I lean my body forward instead of back. With glute max, I was leaning my body backwards. With quadriceps, my knee stays straight and I lean forwards. Last one, which isn't on the list, is going to be the adductor gait. You ever been to the gym and worked adductors, or torn an adductor or strained it? Adductor gaits are antalgic gaits. Their hand will be here, and they'll usually walk, really lean forward like that. So you see my whole body's leaning forward for an adductor. How we doing? Let's take a break. Thanks for watching. Don't forget to hit that like and subscribe button. It helps our channel out a lot. If you like this type of material, check out these other videos on special tests within each region of the body, as well as some in-person recordings of me teaching orthopedic assessment theoretical concepts to a live class. If you would like to take a complete course on orthopedic assessment, check out the link in the description below and make sure to use the coupon code for a super awesome discount. In the course, we go through all of the theoretical concepts, as well as how to assess every region of the body and identify many different forms of dysfunctions. All right, see you next time.